Hello, everybody, and welcome to our exciting medical sciences lecture today entitled From Lamb's Blood to Pig's Heart, a New Renaissance in Transplant Surgery. Thank you so much for everyone joining us today. My name is Seita Diop. I am currently an MSci Medical Innovation and Enterprise student here at UCL, and I'll be your chair for today's event. So over the last few years, we've seen some exciting developments from experts in transplant surgery and biotechnology. In this lecture, Dr. Paul Craddock will be joined by leading UCL experts Ozzy Fernando, Reza Motalebzadeh, and Ashley Boyd. Together, they will explore the history and future of transplant surgery. So we want to keep these lectures as interactive as possible, so please make good use of Twitter and the Q&A function on Zoom throughout to submit your questions for our speakers. And the hashtag to use on Twitter today is hashtag FMS Lectures. I am delighted to now introduce our speakers. We have Paul Craddock. Paul is an honorary senior research associate for the Division of Surgery at UCL. He is a cultural historian and award-winning author based in London. His most recent book is titled Spare Parts, A Surprising History of Transplants. Paul is also a Science Museum Group Senior Research Associate and visiting lecturer at Imperial College London. In addition, we are delighted to welcome Oswald Fernando. Ozzy was a transplant surgeon at the Royal Free from 1968 to 2009, and Reza is an associate professor at UCL Division of Surgery and honorary consultant in renal transplant surgeon at the Royal Free. And Ashley Boyd. Ashley is Associate Professor at UCL Institute of Immunity and Transplantation. So thank you so much for joining us today, guys. And now over to you, Dr. Craddock.
Thanks very much, Seita, and thanks everybody for logging on. It's really fantastic to see so many people. Now I want to start by asking you to imagine peering into a museum case, and inside of that case you see your own dead heart. Now that actually happened 15 years ago to a student called Jennifer Sutton, and she was suffering from a condition called cardiomyopathy, which basically means that the walls of her heart were thicker than they were supposed to be. And the only cure was a transplant, which she was fortunate enough to receive. And a few weeks later, the Wellcome Collection, which is, if you don't know it, is a museum in London, they asked if they could put her excised heart on display in their first temporary exhibition. And Jennifer was invited over to take a look. And when she got there, there was a photographer on hand to take a photograph. Now it was a couple of years later, so in 2009 it was, when I first saw this picture. And it captivated me. And it captivated me because it neatly expressed it neatly expressed the value of a modern life-saving surgical specialism. But it went deeper. I couldn't look at that photograph without the big questions of life springing to mind. Questions about human identity, what it means to have a body, who owns my body. Basically, it was immediately apparent that transplantation went well beyond the operating theatre and science lab. And that led me to ask where it came from and how it evolved. So I became a historian. And I became a historian actually because I wanted to understand not only what led us to performing transplants like Jennifer's, but also why, when people encounter them, they find them so deeply and intuitively meaningful. And that turned out to be a fascinating story, centuries long. And today, in the first part of the lecture, I'm going to give you a little taste of it by telling you a little bit about how modern transplants emerged in Renaissance Italy and in Britain and France slightly later. Now, a lot of people listening to this are here because they're thinking about a career in transplant or in one of the related sciences. So for the second half of the lecture, I'll jump forward in history to tell you about how organ transplants came about, and then we'll shift gear a bit to hear from Ozzy, Reza and Ashley, our other UCL experts. And they'll tell us about their experiences working in transplantation and some of the exciting new directions opening up in their fields. They were meant to join me on stage there, but due to COVID restrictions, we had to film their contributions. But they are here too, and they'll join me in the Q&A. And by the end of the lecture, I want to leave you with a sense that transplantation has a rich history going back much further than many people realise, and that the field right now is being redefined by some of the most cutting edge and exciting science. Now, before we jump to Renaissance Italy, I should say that I've studied the history of transplant surgery for over a decade now, and I've come to realise that it's actually one of the world's oldest procedures, not just in myths and legends, although they are there, it is there too, but also in surgical practice itself. So skin grafts have been around for millennia, and they're mentioned in some of the earliest surgical manuals, like the Sushruta Samhita from India in the 6th century BC. And they seem to have emerged from horticultural grafts. It's actually more or less the same procedure transposed from fruit trees to humans. Even modern transplants have a fascinating 500-year history, starting in Renaissance Italy. And I can barely scratch the surface of that history here, as I said a moment ago. But if you're interested in finding out more about that, I have a book, as Sata mentioned, called Spare Parts, and it's out now in the UK, published by, published by Penguin, and will be out in May in the States, published by St. Martin's Press. And it's available wherever you get your books, and there's an audio book, but I narrate too, and I understand Diana or Kate has put a link in the chat as well. So let's start with how modern transplants came about. So by the 14th century, we start to see references to secret skin grafting techniques performed in various parts of Italy, techniques similar to the ones mentioned in ancient India actually. But transplants in this era in Italy weren't part of any formal medical framework. In fact, they were performed exclusively by peasants. And typically, they'd use their grafting to build new noses from people who'd lost them. So whether that was through a saber wound, as a result of a punishment, or even syphilis. And men would come from all over Italy to see these secretive families of surgeons and have their noses and ears and whatnot replaced. The story of modern transplant starts when a renegade surgeon called Leonardo Fiorevanti, who you can see on the left on your screen now, when he hoodwinked one of these peasant families into giving up their secret. And he did this by pretending to be the relative of a potential patient. And he convinced the surgeons to let him watch them. And he made notes while pretending to be disturbed by all the blood. And that was in 1549. And it took another 50 years for transplants to make it into the medical establishment, when another surgeon, Gaspare Tagliacozzi, who was a student of Fioravanti's student actually, and a university professor, when he wrote about them in his own book. And it was Tagliacozzi who made transplants into procedures that could be understood and taken seriously in the medical establishment, which traditionally would shun any common sense remedies from ordinary people. And transplant surgery at the time was definitely a common sense remedy. It was a peasant operation. And by the way, the image you can see next to Fioravanti is taken from Tagliacozzi's 1597 book on the subject. Now, these days, surgeons and bioengineers are sometimes accused of playing God, or some variation of that. And they have to defend themselves from such criticism. And it happened most recently with the pig heart transplant you might have read about. It wasn't the only criticism people raised about that, but it's perhaps one of the ones that comes up the most often in history. And Tagliacozzi also had to face that in the 1590s. The moving body parts was a big deal in the Renaissance too, even if that was only skin. Because if you as a human meddled with nature, which is something God has already supposedly made perfect, you risked disturbing the natural order and creating a monster. And this is part of a wide debate in the period that seems to have touched every part of life. So, for example, if you go to a Renaissance garden in Italy, like the Villa d'Este near Rome or Boboli Gardens in Florence, you'll see plenty of statues and things depicting various mythical monstrosities, like the two on the screen now. And that's because in Italy at the time, gardens themselves were also seen as abominations. They too were examples of human beings presuming to impose order on an already divinely ordered world. Well, in surgery, Tagliacozzi not only had to write about the skin graft technique itself, but he had to fill most of his massive book with an argument that he wasn't destroying the divine creation, but that people came to him because he could restore it. And the image on the right shows the perfect nose from Tagliacozzi's book that he insisted that he was restoring. So in Italy, these mythical monsters were seen as a kind of a warning about the inherent dangers of transplantation. But what's interesting is that only 3 or 4 decades later, particularly in Britain and France, these same mythological creations became inspirations for a different kind of transplant, which is a blood transfusion. So one of Ovid's, sorry, my thing, sorry, there we go, it didn't seem to be working. My PowerPoint. One of Ovid's stories, the story of Medea, actually included a kind of blood transfusion, where Medea slits her father-in-law's throat, drains his blood, and rejuvenates that blood with a magical potion. Then she puts that blood back into the wound that she created. In some versions he drinks it though. And he starts to transform back into a young man. And actually this exact story inspired the first blood transfusions in Britain and France in the 1660s, where the first scientists to look at transfusion included Christopher Wren, who would later, of course, become a famous architect. And other big names were involved too, like Robert Boyle and John Wilkins. And they'd use things like hollowed out porcupine quills and reeds to transfuse blood, first from animal to animal, but then from animal to human. Now I'm going to show you some 17th century depictions of these operations. So if you're squeamish and you don't like that kind of thing, you might want to look away now for a moment, and then I'll let you know when it's safe to look back again. So there they are on screen now. The idea was that a young animal's blood might be able to make a person younger, just like Medea's magical potion. Other doctors took the idea a step further. One seemed to think that transfusing cat's blood would cure epilepsy. Others looked at the nice and innocent, sweet little lamb, the Lamb of God, and thought that its blood would be pure enough to treat insanity. And it seems the British public, for most part at least, well, they found it hilarious. In fact, scientists were often the butt of jokes in this period. People would listen to them prattling on about pointless things like weighing air, and in this case, curing madness by transplanting purity from a lamb, and they'd have a good laugh about it. But on the other hand, some felt that transfusion was tantamount to transplanting the soul, which meant that for some people, especially in Catholic France, it wasn't a laughing matter. It might be possible to transplant the purity of a lamb, they might have thought, but or of a youth, of a calf or something. But wouldn't it mean that it's also possible to transplant woolliness or bovine stupidity? Now, if you looked away a moment ago, you can look back at the screen again. I've changed the slide. And I'm going to leave the earlier history of transplant there. I mean, there is actually so much more which you can read about in my book, of course, if you're interested. But we can already see in these early years some themes emerging that will be familiar to the modern professional, like the charge levelled against transplant surgeons and people in biology that they play God, or the supposition that transplants can in some way change who you are, And that's surprisingly a trope we see throughout history. And we haven't talked about it today, but there's also an analogue for the illegal organ trade in the 18th century, when dentists would cajole little children into giving up their newly erupted adult teeth to be transplanted into the mouths of rich people. But now I want to jump forward to the second part of the lecture and look at the start of organ transplants. So the year 1900-1901, that was a big year for transplantation. That's when Karl Landsteiner devised the modern method of blood typing, you know, the one A, B, and O. It's the system we use today. It's also when a surgeon called Alexei Karel invented a way to reliably sew together blood vessels, which of course meant that there was now a way to sew organs into bodies. Karel is the man on the left, and by way of introducing this second part of this lecture, I want to tell you a bit about where his foundational technique came from, and actually take the spotlight away from him a little bit. So I'd like to actually highlight the woman on the right. That's Marianne Leroudier, and she was a seamstress, and she actually taught Karel how to sew. Now, Karel's biographers rarely mention her name, and they seem content with telling us that Karel was simply inspired by a seamstress. And when she is mentioned, it's usually only as a historical tidbit meant to show how much of a genius he was for pursuing such an expert. But my research with the embroiderer Fleur Oakes suggests that elements of Karel's technique can be found in Leroudier's work, and that organ transplant techniques, at least partly, evolved from 19th century French embroidery. And I'm keen to highlight her here because, for all the credit that Karel obviously does deserve, it was International Women's Day last week, and she's an almost entirely unsung woman in a male-dominated history. And her contribution was actually incredibly important because recognizing that organ transplants at least partly emerged from French embroidery goes some way to explaining how transplant surgery shifted from a more or less bloody and quite primitive affair for the previous 400 years to being a highly developed and sophisticated craft in the 20th century. And it's this sophisticated modern transplant surgery and science that grew out of this craft that our three guests are experts in. So I'm going to introduce you to the first two, the transplant surgeons Ozzy Fernando and Reza Mutallabzadeh. Together, their careers, well, they span almost the entire history of kidney transplantation in this country. So Diana's going to play you the first video now, and I'll let them introduce themselves properly.
I'm Oswald Fernando, but everybody calls me Ozzy Fernando, Ozzy. And I've been a transplant surgeon for the major part of my surgical life. Started at the Royal Free Hospital in 1968, and I have continued until I retired in 1999, and then did my own locum for a further 10 years. So I've been in transplantation at the beginning, in the middle, and now seeing it growing more and more. As soon as I started working, the then boss, John Hopewell, told me, well, we've done 4 transplants, I think it was, and we've had some problems. And they were living donor transplants, but we want to get a transplant program going here, and we need to get cadaver kidney transplants. So in addition to your research into transplantation, you have to help set up this program, which means getting to know about dialysis, and also getting involved in doing the transplants, collecting kidneys. And that was, in short, my job description. Getting the kidneys, say, from another hospital meant it had to be perfused with solution, cooled it down, and then bring it in the cold state, packed in ice. So we had to use a regular picnic box in which there was ice and the kidney stored in a sterile bag. And in the early days, I remember, because we had the feeling that the sooner we transplanted the organ, the quicker it would function. We even had police escorts to take us to the hospital and an escort to bring us back with blue lights flashing, and the transplant surgeon would then have the patient ready in the theater, all set to go, putting the kidney in. To me, it was such a rewarding career, in the sense that the patients you transplant are patients for their life. I've recently been talking to patients who had their kidneys done by me 40 years ago, and they still remain grateful and happy that their life has turned around because of a surgical procedure. So I think it's quite a rewarding career, exciting, to see somebody who's going to die if you didn't get an organ replacement, being able to lead an absolutely normal life, have children, have their own family, do exercise, go back on trips, do all those things. I was on the heath during COVID, walking one day, and there was this chap who went cycling past, then turned around. He was cycling with his wife, turned around and said, "I thought it was you." And then it turned out that I had transplanted her about 40 years ago, and she then admitted, "Oh, did you know that I had 2 children, twins, and they're all doing well? And I have patients I transplanted at Great Ormond Street." And when you transplant children, you not only take the child as a patient, you have to take the whole family, including the siblings, because they are affected by this. So to see how you have to get in and be with them, not just sympathy, empathize with them and go on the journey with them. And it's so rewarding to have that.
I'm Reza Matalibzadeh. I'm a kidney transplant surgeon based at the Royal Free Hospital. I'm also an academic in University College London, and I run a research lab in the Division of Surgery and Institute of Immunity and Transplantation. And I spend my time at work either doing clinical work or running a research team looking at specific aspects of transplantation. So no 2 days are the same, and certainly that applies for me when my days are either split doing research or looking after patients. It is a very hands-on specialty. Even as a consultant, you're making decisions all the time about selection of particular donors that may or may not be suitable for your recipients. In terms of actually doing the operation of, clearly that is a very focused, intense period of concentration and demand that's put on transplant surgeons, but incredibly enjoyable and profoundly humbling to be part of this amazing process where you have such a close connection with your patients and an ability to transform their lives. I think you're based within a university in one of the greatest cities of the world. You will see patients from a completely wide social, ethnic backgrounds. It gives you an appreciation of how disease impacts different communities. You're in a medical school that has multiple different specialties that can potentially pique your interest. So we are a center not just for kidney, but also for liver transplantation. Teaching is a really central component of our focus as consultants and academics. And I think students get a very high level of teaching and supervision that they need to get through the 6 years of medical school. Currently in the UK, we perform it's about 4,000 kidney transplants per year with incredible amounts of success. So at 1 year, there are 98% of patients have a functioning kidney transplant. And in terms of how long a kidney transplant can sort of survive or work for, that can range, depending upon the characteristics of the donor kidney, can range from 12 to 20 years. And we've seen year-on-year improvements in survival of kidney transplants or functioning kidney transplants, certainly from the early 90s to early 2000s. And one of the areas that still has a sort of an Achilles heel in transplantation is how long a kidney transplant can survive for beyond the sort of medium to long term. And that's one of the areas of certainly the focus of my research, is that what things we can do to investigate and improve upon that can improve the long-term survival of kidney transplants. The other aspect is having enough donors for the number of patients who are waiting for a kidney transplant, and certainly the impact that COVID has had on waiting lists, unfortunately, as that has led to an increase in the number of patients waiting for a kidney transplant. And that's where all centers are working harder to try to utilize as many donor kidneys as possible for transplantation. And I think that's one of the main reasons that I decided to be a transplant surgeon, is that ability to make such a profound change in the space of really 24 hours. And to be part of that process is, as I say, an immense privilege.
Thanks very much, Reza and Ozzy. That's Reza and Ozzy and Reza, and they told us about organ transplant surgery. But in recent years, we've seen new and exciting directions opening up in wider transplant science. So Joshua Gerschlach, now working at Harvard, developed a process where human heart cells grow on spinach leaf scaffolds. So using the intricate vascular network of the leaf inside a human body. Then there's Yuji Haraguchi from Tokyo Women's Medical University. She and her team have gone even further and have successfully woven plant material together with animal matter, so grafting algae and rodent to create a hybrid animal-plant material. The pig heart transplants are a part of a similar marriage of disciplines, of transplantation, of cloning, of biotechnology. And UCL is also pushing transplant research into new and exciting directions. So Professor Wenhu Song, she presented one of these public lectures a few months ago on the potential for growing artificial tissues and organs in the lab. And you can see her talk on YouTube. Another scientist, who I'm going to introduce now, at the forefront of stem cell research is Ashley Boyd. So I'll let Ashley speak for herself.
Hi, my name is Ashley Boyd. I'm an Associate Professor at University College London, based in the UCL Division of Surgery and Interventional Science at the UCL Institute for Immunity and Transplantation. And by training, I am an immunologist. I got into the field as an undergraduate, and from there progressed into focusing on transplantation immunology and looking at the immune response to tissues that are transplanted and trying to find ways to get around immune rejection. And that's what brought me into the stem cell field as well. So I'd really considered myself for the last 20 years straddling the fields of stem cell biology and immunology. And we were looking at stem cells as an alternative source of tissue for transplantation, because obviously in transplantation, one of the biggest issues is a shortage of donor tissues for transplantation. There's a huge waiting list, not enough organs to be given to patients that require them. And this is what's led a lot of scientists like myself to think about alternatives such as stem cells. But it's very important to make sure we dot all the I's, we cross all the T's, and we don't skip any steps so that we end up with a therapy at the end of the day which is safe and reliable, and that we're not going to cause more harm than good. And I think that's something we really need to take on board in this field. Now, we're not quite there yet in terms of using them to generate new tissues and organs, but I would not rule it out in the future. And I think it's a very exciting time to get into this field. There's a lot of pathways open to people working in stem cell biology, and the regenerative medicine field is projected to be worth billions of pounds in the next 10 or so years. So myself, I took a pathway where I'm working in academia. So I have a research group, and I also do teaching for undergraduates and master's students and medical students, as well as having PhD students under my supervision. But there are many other ways that you could think about going into this field. You could work in industry and go to work for a company that is developing a new therapy. You could work in communication fields and work for, say, a journal, meeting people, looking at different developments, and then going to many different conferences, which are all opening back up again now the pandemic's over. And I think the great thing about the field as well is it's made me open to other things I wouldn't necessarily have thought about originally. So I now do a lot of collaborative work with engineers, with chemists, with people, mathematicians, people in other fields, because it's become so interdisciplinary. We really have realised that in order to get towards a particular treatment or therapy in the future, it needs many different brains inputting into it to address the issues. If I had the ability to restart my career again now, and I think it would be a wonderful time to do so. There are so many different new technologies that didn't exist back when I was a student that are developing now, that they're really coming on. Things like microfluidics, things like working with decellularization of tissues, things like iPS cells, which are a type of stem cell that can be made from any of the people watching this right now. We can take some of your blood and we can reprogram those blood cells and make them into stem cells that could then be used to generate any particular cell in the body. These technologies didn't exist back when I was a student, and I think that this makes it even more exciting to get into this field. Just as I'd say, we're poised to make so many developments, and I really would say the future is very bright for the stem cell and regenerative medicine field and transplantation science.
That's great. Thank you, Ashley. So in this lecture, I've used the term renaissance, and I've used it for two reasons. First, because I wanted to emphasize how transplant surgery is extremely old, and it's worth celebrating its very rich history. That history from the Renaissance period itself, and also earlier. And second, because I wanted to express how the field of transplantation has become so incredibly diverse and exciting. And I'd like to leave you with the thought that we at UCL are part of driving that science forward. There are so many new and exciting paths to explore, and so many opportunities to be a part of the incredible transplant sciences of the future. So I'm going to hand back over to Seta now for the Q&A, but I wanted to first, of course, I want to thank Kate and Diana and Neff and Seta herself, of course, as well as the Division of Surgery and Interventional Sciences for making this lecture possible. And obviously I want to thank Ozzy, Reza and Ashley for agreeing to be part of this and for joining us in the Q&A. And of course, I want to thank you all for being a wonderful audience.
Thank you so much, Dr. Craddock. That was super, super interesting. And I'm sure the audience agrees with me on that one. Such a fascinating lecture from you. We're going to move on to the Q&A now. And we've had some interesting questions from you guys. I would encourage anyone out there who've got any questions, please use the Q&A. Make sure you send more questions through. I'm just going to start with some questions that we had before, submitted from some participants before. Let's start with the first one. With the rise of COVID, how do you think we can mitigate the risk of spreading pathogens during transfusion, especially viruses?
I think that one's probably going to be answerable by Ozzy, Reza, and Ashley more than me.
So do you want to take that one?
I'll start. Thank you, Ozzy. So COVID has clearly had a massive impact on our work, in everyone's work, and our field of transplantation is certainly no exception. Our patients at high risk, patients who have kidney disease are very high risk of getting COVID and succumbing to it. And so we've changed our pathways and how we manage patients when they come to hospital, when they come to get a transplant, and how we manage patients after a transplant. And all of these pathways are there to mitigate against acquiring COVID, and also treating patients, transplant recipients who get COVID. And these things include testing a patient with a rapid PCR test that we don't normally do for ourselves, but we'll get a result in about an hour. It will tell us if a patient comes into hospital with COVID, and whether they're fit enough to receive a transplant. And the technology and the staff and the pathways we have certainly in our hospital, fortunately, we've not had we've had very low cases, and combine that with the vaccine program, clearly that's been hugely beneficial for society and obviously for our recipients. So it's not just the technology, not just these rapid tests, but also clinical pathways, isolating patients early on, repeated testing of staff and clinicians that have helped reduce risk in transplant recipients.
Thank you, Reza.
Along with that, can I add to that? Because right at the beginning of transplantation, we had a problem with hepatitis. In fact, we had a situation where we weren't able to diagnose patients with not only Hep C, Hep A. There were big problems that evolved as time went on in 1968. Then along came HIV. But fortunately, these conditions have been treated themselves. And now one can take, say, a donor who has HIV and transplant that organ into another patient who may be a patient who suffered HIV and has been treated successfully. So these conditions, COVID is one of the viruses that has come along the line, and we had these problems before, and the vaccines relate to EBV, hepatitis, and the treatment of HIV.
Thank you, Ozzy and Reza, for that. So we have another question coming in. So it is, as kidney transplants currently last 12 to 20 years, what developments are being made to make permanent transplants?
It's a great question. So I think this is the goal of immunological tolerance, which has been the sort of goal of transplant physicians, scientists, and surgeons from the dawn of time, as it were, in transplantation. And there are multiple avenues being explored to improve or to get to this nirvana of immune tolerance. And they include things like engineered T cells or T regulatory cells, to be precise, that are being used to treat cancer. Those are engineered cells to actually kill or fight the cancer, whereas engineered cells are being developed to regulate the immune response so it calms down the immune system, so a transplant can survive for a long time without any immunosuppression therapy. And then there are also treatments being developed to recondition organs prior to their implant. So an organ that comes from a deceased donor can be put on a machine and reperfused and interrogated, not just for its quality, but also actually get treated before it's implanted in a recipient. And that's a really exciting area of research that will hopefully bear fruit and improve the quality of organs that are being transplanted. And those are just a couple of developments. I'm sure my fellow panelists will pick out their favorites or what they think as well.
Yeah, I would have to just agree with what Reza's been saying about. I think one of the major drives to improve the lifespan for organ transplantation is trying to harness the immune system and the inducing that state of immune tolerance where you are able to transplant from unrelated donors into a patient and have that organ be accepted. And right now, I mean, there's a lot of work being done in animal models that are very encouraging, but it's then transitioning that into the human setting that is proving a lot more tricky. And people have been working on this for, decades to try to get it to work, and it's proving quite elusive. But I'd say that we are making incremental advances in that field. So I definitely think that is going to be the way forward. I mean, not only regulatory T cells, but other people are looking at working with a particular type of immune cell called a dendritic cell, which has also been quite important because it interacts and educates a T cell. So thinking about working on a particular type of DC, which is also tolerogenic, it could be one way forward. So I see. I think that might be something that will be successful in the future, but definitely we're a ways away from that right now.
Thank you both. So hypothetically speaking, we've got a question coming in here saying, hypothetically speaking, if one transplants all major organs, does that increase the longevity of the patient?
Sorry, I'm not sure. Can you just repeat that question? I'm not sure I got that.
So I think what they're asking is, as opposed to just transplanting one organ, if you transplanted all the organs, all the major organs, would that improve the outcome for the patient in terms of longevity?
I wouldn't have thought so. I feel you're putting a lot more pressure on the patient to have these multiple organ transplants at the same time. I would think that would be for a start. There are obviously transplants where there are multiple tissues transplanted at the same time. So it's quite common, for example, to do a liver and a pancreas transplant at the same time. But in terms of doing a heart, etc., a liver, a kidney all together, I don't know, perhaps Reza can talk about that in Aussie. But
well, I mean, it's what you're talking about is a body transplant, a whole body transplant. I remember there was an instance where Roy Khan in Cambridge did a liver, kidney, and Papworth did the heart in the same patient. Literally took all the organs, unblocked, and replaced them. I think the patient lasted for a while, but there are a lot of ethical questions that come into play here. How much we can do, what is ethically correct. It's a big field for discussion. Just quite simply, replacing one organ is bad enough, but doing this is even more complicated.
I'd agree with what my fellow panelists have said. I think it's really driven by the clinical need. So there are some patients, unfortunately, who have bowel failure and liver failure, and they get what we call a multi-visceral transplant. These are patients in extremis who are actually running out of access to actually feed. They can't have any lines, for instance, to even give parenteral feeding. These multiple organ transplants are high risk, clearly, and only done in very selected patients where there's obviously a clinical need. There is some evidence to show that in patients who need combined liver-kidney transplants, the liver acts as a sort of a tolerogenic organ, and there's less rates of rejection of kidney transplants in simultaneous liver-kidney transplants. But again, that's driven by the clinical need of the patient, and we wouldn't do a combined liver-kidney transplant for every patient that needs just a kidney transplant.
Okay, thank you. So we have another question that asks, how viable is transplantation from other animals, for example, pigs, but any other large animals, any other organisms?
That has been the dream that we've had, xenotransplantation. And throughout my career, every meeting that I went to, there was discussion about this. And as you know, recently they had a heart transplant from a pig into a human being. Sadly, that patient just passed away recently. It's sort of how much one can genetically modify the organ to enter into a human being.
Yeah. I mean, the major issue is that you've got, I mean, with normal transplantation from a recipient, a donor into a recipient, obviously there's genetic mismatch there. We try to match as best we possibly can, but obviously from an animal into a human, it's even more, there's even more differences there. And it unfortunately causes, the situation called xenotransplantation, it causes a hyperacute rejection. So rejection occurs very, very quickly. Now, the pig transplant into human that recently occurred was actually a genetically modified pig. So it had been engineered to not express these particular antigens that induce this hyperacute rejection. So some people think that this could be the way forward, just given that there's a lot of similarity in organ size between pigs and humans, and they can be bred quickly in terms of how long it takes to have a pig grow. But obviously it's something that's not going to be available for everyone yet. I mean, there's a lot of work that has to go into studying this. That was the first patient that was transplanted in January, and as you mentioned, passed away recently, which is very sad to hear. But I mean, perhaps, who knows, the future we may turn to using these transgenic pigs as donors. There's obviously lots of ethical issues there. Some people may not want a pig organ in them, maybe even for, say, religious reasons as well. Although I think it has been agreed by various religions that it is allowed because it's an extreme case to save the patient's life. But yeah, it's something that we need to do. We need to do more work on this. And in terms of other animals, it's something that without these modifications, then it's just, I don't think it's going to work. The patients will obviously have to have very strong immunosuppressant drugs as well, which can impact the lifespan of the organ. So,
just an interesting note from way back. In the 17th century, we were convinced that xenotransplantation did work. We transplanted blood from animals to humans, and we thought that, I mentioned the lamb blood transfusion, and some people were convinced that worked because you can actually take a tiny amount of blood that isn't meant for your body, even if it's animal blood. I mean, you wouldn't react very well, and then you'd have a massive fit, and you'd become very, very ill. But because you'd become very, very ill, if you were an insane person, to use that historical term, then you would tire yourself out, and you'd no longer have the energy to be, to behave in that manner. So it would look like the transfusion had transfused the purity, had transfused the calmness. Of course, it would wear off, and you'd need a second dose, which would more than likely end up killing you in the end. But I thought I'd offer that little insight from history.
Very interesting.
Thank you, Paul. So we have another question that is changing directions a little bit. So looking at organ and stem cell transplants, are any of the two promising in treating neurodegenerative diseases such as Parkinson's?
Yes, I would say that they're actually quite promising for conditions like Parkinson's. In situations where there is a particular product, for example, of a cell that is lacking. So in Parkinson's, the cells that produce the dopamine, the dopaminergic neurons, are the ones that start to die. So the idea is then if you can take stem cells that are capable of producing dopamine, you could replace that by transplanting them. So there are people working on this right now. But as I mentioned before in the video, with any sort of stem cell transplantation, we have to be very careful that the cells are, first of all, they function correctly, and they're going to function when you put them into the patient. There are not going to be any residual undifferentiated cells that could potentially form tumors, for example. So there's not going to be an awful lot of work to try to get rid of any cells like that, to make sure the cells that you've grown in the lab that could be the eventual product to be given to a patient are going to be tested extensively so that we know they function, etc. They do what they need to. They can, when they're injected into the person or put in somehow, that they make it to the site that they need to reside in. And there's a lot of work ongoing to try to make sure we can, get over these barriers right now. And then the other issue as well is that we keep talking about today is about the immune system. So there's also going to be an issue with that immunological compatibility. So there's some people are working right now on a particular stem cell, which is known as a potential universal donor, one that can match many different humans and are the matching, the tissue typing between recipients and donors is known as HLA. And so there are people working on making specific stem cell lines that can be then used to match to different populations, different people within our population. So the idea in the future, I guess, could be that you will use this particular universal stem cell line and use that to then grow specific cell types that could be used for therapy. And one such avenue I'd say that is most promising is for neurodegenerative conditions like Parkinson's.
Thank you, Ashley. So we have a couple more questions about kind of xenotransplants. What do you, any of you four rather, think went wrong with the pig heart transplant to the human? And what in future do you see, what future do you see in animal to human organ transplants?
I mean, I think, first of all, I think one has to look at the advances that have been made in xenotransplantation. I think, this is work which has been going on for the last, I think, at least 20, 30 years. And actually, the result that was achieved, although obviously in the end, not great for the patient, he only survived for a month. Even getting to that month was quite a landmark event. As Ashley said, these transplants notoriously undergo hyperacute rejection. So they reject within the first 24, 48 hours. And the ability to genetically modify an organ from a pig by switching off certain genes and adding certain human genes, that really is an amazing technical advancement. And I don't think we should lose sight of that fact. Clearly, the immune response to a xenotransplant is fiendishly complex. There are also the issues of intense immunosuppression that has to be given, and that all carries side effects. So these factors potentially played a role. We don't have all the details about that that particular xenotransplant. The xenotransplant, there was a kidney xenotransplant into a human. That was actually a human who was brain dead. Again, that has only been published in the last couple of weeks. clearly there's a lot more work that needs to be done to improve the longevity, but also, as Ashley's also raised, the ethical issues around this as well, and not to mention the costs. I think I saw a figure of almost $1 million to raise a genetically engineered pig. So there are bigger sort of societal questions as well about funding this type of work, actually. And actually, I think that the future may not so much lie in xenotransplant, but actually improving better utilization of the current pool of donor organs that are available, and therapies to increase the longevity of novel therapies to increase the longevity of transplants. And I think that's where you can actually see, in the next sort of 5 to 10 years, things improving, and not to mention also obviously the work that's being done with stem cell transplantation, amazing advances being done with pancreatic devices and beta cell therapies that are being developed from stem cells. So I think those are the areas I feel in the next sort of 10 years that will come on leaps and bounds.
Thank you. And I guess it leads us nicely into hopefully our last question before we have to wrap up today. This is mostly for you, Dr. Craddock, but I'm sure any of you guys might have some responses. So we've got Julio here. He said he's read Spare Parts and it was excellent. So he wants to know, are there any future projects, and how long do you think it will take for transplant medicine to have evolved so much that it will require an updated edition?
Well, thank you. Okay, so the first question was what my next project is. Well, I'm not sure how much I can share about that yet, because I have not spoken to my agent or publisher about it. So I suppose I can't really say, but I have got another project in mind, and it's not to do with transplantation, but it's to do with the history of science, and I suppose the history of how the public has related to science. I suppose that's one sort of general way to put it. And a second edition of Spare Parts, and thank you, by the way, for that lovely comment about enjoying it. There are so many things that I had to leave out of the first Spare Parts. I could actually write a second Spare Parts now. I wouldn't like to put a date on it, but if Ashley or Reza or Ozzy want to tell us about what might be coming up and that might frame a new Spare Parts, that would be very interesting.
Really, if Ashley, Ozzy or Reza, you have any thoughts on that, I'm sure the audience would love to hear. And actually, that is one of the questions that we were asked, what you guys see being the future of transplantation.
Ashley's probably got a lot in her bag that she can talk about.
Ashley is definitely where it's at.
Most likely. Well, there's, as I mentioned before, there's a lot of been a lot of progress in the last sort of 10 years since the discovery of those iPS cells, induced pluripotent stem cells. And within a few years of them being discovered, the person that discovered them was actually awarded the Nobel Prize. It was extremely swift, and it led to many labs, thousands of labs around the world, all working on these cell types. But I mean, in combination, I'd say stem cell biology in combination with some other technologies like 3D printing of tissues, that's a very exciting field. And organoid technology, looking at the more simplified development of organs from stem cells, or even a human cell taken from patients, is really a really nice platform for drug testing and disease modeling. There's people working on making, as Paul mentioned earlier, making scaffolds and populating those with cell types, in combination with other technologies that we now have, where we are able to interrogate individual cells within an organ and a single cell genetic screens, etc. I think there's many different areas that we're going to be exploring, I think, in the future. As I say, it's an exciting time to be in this field and watch this space, really.
Absolutely. Thank you so much. So very sadly, we're going to have to leave it out we've run out of time, so we're gonna have to leave it there. Any questions that we haven't had the chance to ask, I'm so sorry about that. But if you could please give us your feedback about today's session. We'll be sending around a survey after today's session. If you give us your feedback, let us know what your thoughts were. That'd be really, really appreciated by the team. Also, we do have another exciting, fascinating lecture happening on the 19th of April with our very own Deepak Kalaskar, Associate Professor of Bioengineering in the UCL Division of Surgery. And we would love to see as many of you there as possible. And the details for this event will be forwarded on our website shortly. So I just want to say a massive thank you once again to Dr. Craddock, Ozzy, Reza, and Ashley for your time today and your comments in the audience and the questions. And I wish everybody has an excellent evening today. Thank you so much, and bye-bye.
Thank you.
Thank you for having us. Thank you. Thank you. Bye-bye.